Hello. 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 Just wait. Check my voice. Hello. Hello everyone. Hello everyone. Okay. So just wait. Hello. Good evening, all of you. This is a FMG session in which we will discussing the 25 important MCQs related with the FMG exam. Okay. 25 MCQs or 25 frequently asked topics we'll discuss today. Okay. So we'll discuss the electron transport chain, the inhibitors of electron transport chain. Then we'll discuss the glucose transporters, their distribution. Then niacin, thymine pyrophosphate means B1, vitamin B1 we'll discuss. Then pyruvate dehydrogenase complex, 3 enzymes, 5 coenzymes of pyruvate dehydrogenase complex and similar enzymes as that of pyruvate dehydrogenase complex that we will discuss along with the regulation of pyruvate dehydrogenase complex. Then we'll discuss the different vacuum tenors and also we'll discuss the order of draw when we collect the blood sample. Then zinc and copper, this is also important topic. Then GAG, which is frequently asked topic in any entrance examination, glycosaminoglycans, different glycosaminoglycans, their distribution, their functions. Then omega-3 fatty acid and phospholipid that we will discuss. Then glycogen storage disorder, one of the important topic for any entrance exam preparation. Then acetyl coenzyme A means acetyl coenzyme A carboxylase enzyme. This is a rate limiting enzyme in the fatty acid synthesis. How it is regulated and what are the cofactors required for the acetyl coenzyme A carboxylase enzyme that we will discuss. The alkaptonuria, black color urine, alkaptonuria, the inborn error of metabolism. This is important for the FMG examination. Then SDA and respiratory quotient, specific dynamic action and respiratory quotient of the different foodstuff. Then collagen, how it is made up of, what is role of vitamin C and what is role of copper in collagen synthesis that we will discuss. How histones are responsible for organization of DNA. This is important topic in the entrance examination. Then DNA repair mechanism, various DNA repair mechanism and their associated disorders. These are the important topics for the FMG exam. Then acid-base disorders, different acid, how to diagnose the acid-base disorder. What do you mean by diabetic ketoacidosis that we will discuss here. The congenital jaundice, various types of congenital jaundice and what happens to the level of UDP glucuronil transferase, what happens to unconjugated bilirubin and direct bilirubin in the various type of jaundice that we'll discuss. The one of the star mark question or top rated question is the Gaucher's disease that belongs to lysosomal storage disorders that we'll discuss here. Then competitive inhibition, different examples of competitive inhibition and different graphs, pattern of different graphs, that is the Lineweaver-Burke plot in competitive inhibition that we will discuss. Okay, then gout, the primary gout, secondary gout, what is the treatment, that is allopurinol is the competitive inhibitor which is given in the treatment of gout. Then Leishnian syndrome, which enzyme is defective in the Leishnian syndrome and what are the clinical features of Leishnian syndrome that we will discuss. The lipoproteins, different lipoproteins, that is HDL, LDL, VLDL, IDL, chylomicron, their properties, their characteristics, their metabolism and disorders, two important disorders, hyperlipoproteinemia. In hyperlipoproteinemia, the two important disorder, the first and second, that is important, that we will discuss. The homocystinuria, the ectopia lentis, mental retardation, and what happens in the homocystinuria, which amino acid to be given and which is restricted, that we will discuss. Then order of draw, while collecting the blood sample, what should be the order of collection of putting the sample into the various tubes or vacuoteners, that we'll discuss. And the glycogen phosphorylase, this is one of the important topic which is frequently asked in the entrance examination, how it is regulated, regulation of glycogen phosphorylase. So these are the important topic, the simple topic but basic topics, and the frequently asked questions in the FMGE examination. So for the complete details or complete PYQs, you can watch the FMG sprint, which is available on the YouTube on the Meded channel. Also the FMG part 1, part 2. There is series, FMG series in the Meded channel that is in the detail about the FMG question. Now we'll start with the one by one. See, first question, which of the following block the flow of electron through FO complex? Remember, this is FO, O for oligomycin, FO complex of ATP synthase. Okay, so this is simple, block the flow of electron through FO complex of the ATP synthase. Okay, oligomycin. Oligomycin is the inhibitor of FO. Okay, O for oligomycin, and F1, 1 denotes it was first factor which was isolated from the mitochondria. So here answer is oligomycin. Here cyanide is the complex 4 inhibitor, atractyloside, it is a it blocks the ADP ATP transport. Then oligomycin inhibitor of the FO, and the azide, it is a inhibitor of complex 4 of electron transport chain. तो यहाँ पे आपको सभी complexes के inhibitor, the topic important here are the inhibitors of complex 1, 2, 3, 4, then uncouplers which disrupt the proton gradient across the membrane, that they are known as uncouplers, then ionophores, and the inhibitors of oxidative phosphorylation. These are the important for the entrance examination, important for the FMG exam. Now see, this is a flow of electron. This is how the flow of electron occurs. Now from the reducing equivalents which are generated in the various pathways, various metabolic pathways, there is generation of reducing equivalent and it enters the electron transport chain. Now the various components and complexes of electron transport chain, they are arranged in a ascending redox potential. More negative is the redox potential, it has tendency to lose electron. More positive is the redox potential, it has tendency to accept electron. So it is increasing redox potential, negative to positive redox potential. Now from NADH, it is for accepted by the complex 1, then coenzyme Q, then complex 3, cytochrome C, then complex 4, and O2 is reduced to form the water molecule. Now during the movement of electron, there is pumping. There is pumping of protons. See, there is pumping of protons from the complex 1, complex 3, and complex 4. So simultaneous pumping of proton occurs, and that develops the proton gradient. ये हमने बोला है कि जैसे कि इलेक्ट्रिसिटी, हाइड्रो इलेक्ट्रिसिटी हम प्रोड्यूस करते हैं ना, तो पानी को ऊपर के लेवल पे लेके जाते हैं और फिर फोर्स से पानी नीचे आता तो वो टरबाइन घुमाता है. सो लाइक दैट, सो देयर इज डेवलपमेंट ऑफ प्रोटॉन ग्रेडियंट हियर, और इसको दूसरा कोई रास्ता नहीं है वापस आने को. देयर इज नो अदर वे टू रिटर्न दिस प्रोटॉन्स. तो ओनली वे फॉर दिस प्रोटॉन इज थ्रू द FO यूनिट. इट इज थ्रू द FO यूनिट. सिर्फ यहीं से वापस आ सकते हो. So while the movement of protons from this FO unit, it rotates the gamma handle that causes the confirmatory change in the beta subunit of ATP synthase, that is F1 subunit, beta subunit of F1 unit, and it causes the formation of ATP. So this is like a hydroelectric plant, okay, जहाँ पे electricity produce होती है water से. So this is pumping of protons. Now see, 4 protons from the complex 1, 4 protons from the complex 3, and 2 from the complex 4. Total 10 protons are pumped out when electron is transferred. Okay, 10 protons. For the synthesis of 1 ATP, 4 protons are required. So NADH will give 2.5 ATP, as this step is bypassed here when it is from the FADH2. So only 6 protons are pumped out and it will give 1.5 ATP. So remember, NADH will give 2.5 ATP and FADH2 will give you 1.5 ATP in the oxidative phosphorylation. Now see, these are the inhibitors of electron transport chain. So this is complex 1 inhibitor which blocks the movement of electron from complex 1 to the coenzyme Q, that is pyridine amobarbitol, which is a barbiturate rotenone. It is a insecticide and also a fish poison. This is important, remember this, rotenone, insecticide and fish poison, which inhibit the complex 1 of electron transport chain. Now complex 2, this malonate, it inhibits the succinate dehydrogenase enzyme, and this carboxyl and trienoyl trifluoroacetone, carboxyl and trienoyl trifluoroacetone, it inhibits the movement of electron from complex 2 to the coenzyme Q. Okay. Then complex 3, it is inhibited by British anti-levisite and the antimycin. Then complex 4, it is inhibited by the gases cyanide, carbon monoxide, hydrogen sulfide and azide. These gases inhibits the complex 4. These are the inhibitors of various complexes of electron transport chain. While there are inhibitors of oxidative phosphorylation, that includes oligomycin, that includes the venturicidin. Okay, see this table. So this is important table from the Leininger biochemistry. So ATP ADP transporter, it is blocked by the atractyloside. This is atractyloside which blocks the ATP ADP transporter. Then FO unit, it is inhibited by oligomycin and it is inhibited by venturicidin. Okay, F1 subunit, it is by the arovertin. Arovertin inhibit the F1 subunit. Then uncouplers, what is the role of uncoupler? See this diagram. Now there is development of proton gradient across the membrane when pumping of proton occurs from matrix to the intermembrane space. So uncouplers increases the permeability of this inner mitochondrial membrane. That's why this proton gradient will not develop. So what is the role of uncoupler? Chemical or physiological uncoupler, the role is it increases the permeability of inner mitochondrial membrane so that proton gradient will not develop. This is a function and mechanism of action of uncouplers. So there are various uncouplers. They are known as physiological uncouplers and chemical uncouplers. Chemical uncouplers includes 2,4-dinitrophenol, dinitrocresol, then fluorochlorocyanide phenylhydrazine, that is FCCP, and aspirin in high doses. These are the chemical uncouplers. These are the physiological uncouplers and has importance. For example, thermogenin it has important in the newborn for preventing the newborn from the hypothermia. Okay, so thermogenin, there is production of heat without production of ATP, so it is important, thermogenin. Then thyroxine, T4, thyroid hormone, thyroxine, long chain fatty acid and unconjugated bilirubin. That's why the unconjugated bilirubin, high level of unconjugated bilirubin in kernicterus, it damages the brain. This is the mechanism because it is a physiological uncoupler. So these are the chemical uncouplers, these are the physiological uncouplers. Ionophores, they increases the permeability of other ions, for example potassium ionophores. So ionophores examples are valinomycin, gramicidin and nigrosin. Valinomycin, gramicidin and nigrosin. So this is very, very important table from the Leininger chemistry. Okay, so this is all about the inhibitors of electron transport chain, inhibitors of oxidative phosphorylation, uncouplers, physiological uncouplers, chemical uncouplers, and the fourth one is the ionophores. They increases the movement of other ions, so they disrupt the proton gradient which is developed across the membrane. Now coming to the second question, which of the following glucose transporter is insulin dependent and present in skeletal muscle, heart and adipose tissue? This is top rated question. The glutes are very, very important for any entrance examination. What is glutes? Glucose transporter. First we'll discuss the answer here. The answer is GLUT4, which is insulin dependent and present in skeletal muscle, heart and adipose tissues. The other insulin dependent glucose transporter are GLUT8 and GLUT12. 8 and 12. Now what is the specialty of the GLUT? These are the carrier mediated transport, means it is a type of facilitated diffusion. Carrier mediated facilitated diffusion, GLUTs. Okay, the primary channels for the transport of glucose in the intestine is the SGLT1, sodium dependent glucose transport, that is SYMPOT. But GLUTs are important for the glucose transport. It is a type of facilitated diffusion. So facilitated diffusion will follow the पिंग पोंग मैकेनिज्म. पिंग पोंग मैकेनिज्म मीन्स तो रिसेप्टर्स जो रहते हैं वो ट्रांसपोर्टर्स जो रहते हैं वो पहले ऐसे इन्वर्टेड यू ऐसे यू शेप में रहेंगे. यहाँ पे सोलूट अगर बाइंड हो गया तो वो ऐसे कॉन्फ़िगरेशन में चेंज हो जाते हैं. दैट इज नोन एज फैसिलिटेटेड डिफ्यूजन बाय पिंग पोंग मैकेनिज्म. फर्स्ट इज द पिंग स्टेट, देन इट इज पोंग स्टेट. Ping state and Pong state. Now, after this, the second important question in the GLUT transport or any transport mechanism is the kinetic, the enzyme kinetic. See, in the facilitated diffusion, it is a carrier mediated transport. So, if it is a simple diffusion, it will be in the direct proportion. This is solute concentration, and this is percent maximum rate of absorption. Okay, so if it is not carrier mediated, it is directly proportional means increasing solute concentration will increases the absorption rate. Okay, while in case of facilitated diffusion, it is like this. It is like enzyme kinetic. So it is it will show the saturation. So that is known as saturable kinetic. It is shown by the carrier mediated. So GLUTs, GLUT, GLUT transporter, it is a carrier mediated, it is a facilitated diffusion. So it shows the saturable enzyme kinetic. It will show the saturable enzyme kinetic. So this is simple diffusion. It is directly proportional, but it is hyperbolic curve in case of facilitated diffusion or any carrier mediated transport. What is the special characteristic of GLUT5? It is present in the GLUT5. It is intestine. It is for the absorption of fructose, facilitated diffusion. 5, facilitated diffusion, absorption of fructose from the intestine. GLUT7, it is present in the endoplasmic reticulum for the absorption of glucose. GLUT2, it is present in the liver, beta cells of the pancreas. It is present in the on the basolateral surface of the intestine. It is present on the basolateral surface of the proximal convoluted tubule or renal tubule. So it is important for the regulation of blood glucose. GLUT2. GLUT2, it is important for the regulation of blood glucose. Now see this chart. Remember these 1, 2, 3, 4, 5, 7. Remember these glucose transporters, and apart from this, remember GLUT8 and GLUT12. 8 and 12, these are insulin dependent glucose transporters. GLUT8 and GLUT12, these are the insulin dependent glucose transporters. Now see GLUT1. What is distribution? GLUT1 is very important because it is most widely distributed glucose transporters. It is most common glucose transporter in the brain. It is most common in the placenta. Okay, it is most common in the placenta. It is most common in the brain. Also, it is present in the kidney, colon, RBCs and retina. 𝐒𝐻 plays for RCB is the mnemonic to remember the distribution of GLUT1. 𝐒𝐻, kidney, plays placenta for RCB. Here RBCs, brain and colon. Okay, so this is the distribution of GLUT1. It is important for basal glucose uptake. It is present for it is important for basal glucose uptake. It is widely distributed, abundantly present in RBCs, major in brain and placenta. Remember RBCs, the anaerobic glycolysis is the only source of energy for the RBCs, and the another important pathway in the RBC is the HMP shunt. Just wait. So two important pathway in the RBCs. First one is the anaerobic glycolysis. So there is production of lactate. Glucose is utilized and lactate is produced in the anaerobic glycolysis. And second important pathway in the RBCs is the HMP shunt. And RBC is the tissue which only utilizes the glucose, whether it is well-fed state, fasting or starvation. It utilizes only glucose. So GLUT1 important. Then GLUT2, it is again important because it is present on the basolateral surface of the intestinal cell, and also it is present in the renal tubule. Also, it is liver sinusoidal surface and beta cells of the pancreas. It is important for regulation of blood glucose. Now see, suppose this is intestinal cell, this is lumen. If this is lumen and this is blood, this is blood. So here it is by the SGLT, sodium glucose transport, SGLT1, sodium and glucose, it is transported into the intestinal cell, and via the 2 GLUT2, GLUT, GLUT2, it is transported out into the blood. This is a role of GLUT2. Okay, so GLUT2, it is present in the liver sinusoidal surface, beta cells of the pancreas. It is present in the basolateral surface of intestine and the renal tubule, proximal convoluted tubule. So GLUT2, it is important. GLUT3, remember, only for the neuron it is important. GLUT4, it is insulin dependent glucose transporter present in the skeletal muscle, heart and adipose tissue. So it is insulin dependent, it is very, very important. GLUT5, it is related with the fructose 5 facilitated diffusion. It is present in small intestine, testes and sperm. GLUT7, it is present in liver endoplasmic reticulum, and it is important for transport of glucose in the endoplasmic reticulum. So this is all about the GLUTs. Okay, most widely distributed, it is GLUT1. Most abundant is the GLUT1. GLUT2 present on the basolateral surface of the intestine. GLUT2 present on the basolateral surface of proximal convoluted tubule. For the regulation, GLUT2 is important. GLUT1 is widely distributed. GLUT3 is present in the neuron. GLUT5, it is for the transport of the fructose. Then GLUT4, it is insulin dependent glucose transporters present in the skeletal muscle, heart and adipose tissue. And GLUT7, it is endoplasmic reticulum. It follows the saturable kinetic. The curve will be like the enzyme kinetic curve, hyperbolic curve, because it is carrier mediated transport, and any carrier mediated transport will show the hyperbolic curve, saturable kinetic. There is one level, मतलब एक आप अगर सोलूट का कॉन्सेंट्रेशन बढ़ाते जाओगे तो ट्रांसपोर्ट प्रोपोर्शनेटली इनिशियली बढ़ेगा, लेकिन बाद में सैचुरेशन अचीव हो जाएगा. Further increasing the solute concentration will not increase the transport across the membrane. So that is saturable kinetic. It's shown by the facilitated diffusion or carrier mediated diffusion. That also includes the active transport, means primary and secondary active transport, which is also included in the saturable kinetic shown by the facilitated diffusion. While the passive diffusion, simple diffusion, in case of simple diffusion, it is directly proportional. So this is second question. Now third and the frequently asked vitamin as a clinical case is the thiamine and the niacin. Thiamine, niacin, beriberi, thiamine, niacin, pellagra. So remember this, there are number of causes of pellagra that we'll discuss. See, a 34-year-old male was on the maize as a staple diet for prolonged period. Okay, he presented with diarrhea, lesion over his neck. See the lesion over his neck. As shown in the image below, the condition occurs due to deficiency of. This is a typical Castle's necklace dermatitis. Castle's necklace. So Castle's necklace and glow and stalking appearance of hand and feet. It is a feature on the sun exposed part of the body. The rash or the dermatitis on the sun exposed part of the body is a feature of niacin deficiency. Castle's necklace bolte isko. So that indicates the pellagra. Also there is diarrhea. Also there is diarrhea. The classical 3Ds, diarrhea, dementia, dermatitis, these are the features of the pellagra. And what are the causes of pellagra? It includes the heart nerves disease. See, heart nerves disease. What happens in the heart nerves disease? There is defect in the absorption of tryptophan. Tryptophan is connected with niacin. Tryptophan is connected with niacin. Okay, because 60 milligram of tryptophan will give 1 milligram of niacin by the kynurenine anthranilate pathway. By the kynurenine anthranilate pathway. In the heart nerves, just wait. In the heart nerves disease, there is defective absorption of tryptophan from the intestine, heart nerves disease. Second, in the B6 deficiency, which is required for the kynureninase activity in tryptophan to NAD conversion. So B6 deficiency, there is niacin deficiency also. Okay, in the B6 deficiency, heart nerve disease, B6 deficiency. Then carcinoid syndrome or argentaphinoma. Carcinoid syndrome or argentaphinoma. It is a tumor of argentapin cell, serotonin producing tumor, where tryptophan is diverted for the serotonin production, and that gives the symptoms like flushing, increased blood pressure and all. That is known as carcinoid syndrome. As tryptophan is diverted for the serotonin conversion, it is the NADP, it is less produced in that pathway. That's why there is niacin or niacin deficiency in the carcinoid syndrome. Then maize eating population, as a staple diet, maize, it is present in bound form. It is present in bound form, so it is not available for absorption. When we eat the maize, niacin is present in the maize in bound form, so it is not available for the absorption. Also, the jawar eating population, jawar, when it is consumed as a staple diet, it has high leucine content, which inhibit the enzyme QP-artase enzyme, quinolinate phosphoribosyl transferase enzyme, which is important in tryptophan to niacin conversion. So these are the causes for niacin deficiency. So these are connected. These are the connected. Heart nerves disease, pyridoxine, it is connected. Carcinoid syndrome, serotonin producing tumor, and maize and jawar as a staple diet causes the niacin deficiency. Remember, diarrhea, dementia, dermatitis. So Castle's necklace, glove and stalking appearance of hand and feet, diarrhea, and dementia, loss of memory loss. Ghazni movie dekhiye na, memory loss. So it causes the pellagra. So these are the symptoms of pellagra. So niacin deficiency causes the pellagra. Zinc deficiency also causes the dermatitis, but that typically involves the acral part of the body. Mouth, nose, finger, toes and perineal area is involved in the zinc deficiency. Also in the zinc deficiency, along with the dermatitis, there is delayed wound healing, and also alopecia is there in the zinc deficiency. Okay, so this is triple D: diarrhea, dementia, dermatitis, and this is diarrhea, alopecia, dermatitis. Diarrhea, alopecia, dermatitis. Apart from this, in the zinc there is defect in the wound healing also. Defect in the wound healing. Thiamine deficiency causes the beriberi. There is neural involvement. The peripheral neuritis is there in the thiamine deficiency. There is calf muscle tenderness, peripheral neuritis in the thiamine deficiency. Also, it causes the wet beriberi that involves the heart, and high output cardiac failure is there in the thiamine deficiency. Iron deficiency anemia, there is decrease in the scholastic performance, loss of interest in the surrounding. Also in the iron deficiency, there is decrease MCV, MCH. Also there is microcytic hypochromic anemia, increase in the total iron binding capacity. These are the indicators of the iron deficiency anemia. So this is about the niacin. Okay. Now see, diarrhea, dementia, dermatitis. These are the feature of niacin deficiency, while diarrhea, alopecia and dermatitis, these are the features of the zinc deficiency. A chronic alcoholic was brought to the hospital with symptoms of confusion, ataxia and sixth nerve palsy. What is your diagnosis? Now this is important question. It is connected with pyruvate dehydrogenase. So here answer is Wernicke's encephalopathy. This is Wernicke's encephalopathy. See, Wernicke's encephalopathy means this is mnemonic to remember: global confusion, ophthalmoplegia, ataxia. In the Wernicke's encephalopathy, in the Korsakoff psychosis, memory loss and psychosis is there. Barlow's disease, it is infantile scurvy, and acrodermatitis enteropathica, this is due to zinc deficiency. Here answer is Wernicke's encephalopathy. Global confusion, ophthalmoplegia, this is plegia, paralysis of ocular muscle. Ophthalmoplegia, ataxia, lack of coordination is there. There is gait disturbances in the Wernicke's-Korsakoff syndrome. Okay, so Goa MP together, it is known as Wernicke's-Korsakoff syndrome. Here only confusion, ophthalmoplegia is there and ataxia is there. So it indicates Wernicke's encephalopathy. It is because of defect in thiamine pyrophosphate enzyme. Thiamine pyrophosphate. Now what is the role here? See, in chronic alcoholic, there is decreased absorption of thiamine from the intestine. Also, there is decreased conversion of thiamine to thiamine pyrophosphate. Thiamine is not converted into thiamine pyrophosphate. This is the active coenzyme form of the thiamine. So, because of this, there is deficiency of the thiamine. Also, thiamine deficiency is there when we eat the rice. when we eat the polished rice, उसको polish करके खाते और सफेद बना के खाते हम लोग. So that polishing removes, it is thymine, it is present on the outer alluron layer of the whole grains. When polishing is done, so polishing removes 80% of the thymine. It removes 80% of the thymine. So polished rice consumption as a staple diet causes the beriberi vitamin B1 deficiency. This is Wernicke's encephalopathy. Another features of this is all about the Wernicke's encephalopathy. There is decreased absorption of thymine and decreased absorption of conversion of thymine to thymine pyrophosphate. Thymine is linked. This thymine pyrophosphate, it is linked with the pyruvate dehydrogenase complex. Also, it is linked with the alpha ketoglutarate dehydrogenase complex. So there is less ATP produced. There is less ATP produced. Also, acetylcholine synthesis is decreases when it is defect in the thymine pyrophosphate. So because of less ATP production, these are the symptoms in the Wernicke's-Korsakoff syndrome, okay, which includes global confusion, ophthalmoplegia, ataxia, memory loss, and psychosis all together in Wernicke's-Korsakoff syndrome. While thymine deficiency, it causes the beriberi, dry beriberi, which involves the nervous system, and it causes the neuritis, peripheral neuritis. So loss of sensation, tingling, pain, these are the symptoms. Calf muscle tenderness, these are the symptoms of dry beriberi. While in the wet beriberi, there is edema, there is fluid accumulation in various spaces, pleural effusion, cardiac effusion is there. Also edema is there, edematous arthritis is there, calf muscle tenderness is there in the wet beriberi. Okay, so this is dry beriberi, wet beriberi. Okay, and Wernicke's-Korsakoff syndrome in the thymine deficiency. Thymine is required for the transmission of nerve impulse. It is important for the chloride channels in the transmission of nerve impulse. Now pyruvate dehydrogenase complex. See, this is the repeat question. This multi-enzyme complex converts pyruvate to acetyl coenzyme A. Identify E1 and E2. Converts pyruvate. See, pyruvate is converted into acetyl coenzyme A. So this is pyruvate dehydrogenase complex. So there are pyruvate dehydrogenase complex 3 enzymes and 5 coenzymes for pyruvate dehydrogenase complex. How many enzymes? 3 enzymes and 5 coenzymes. 3 enzymes कौन-कौन से वो हम डिस्कस करेंगे कौन कौन से. हियर आंसर इज E1 and E2 means pyruvate dehydrogenase and dihydrolipoyl transacetylase. This is answer. Fourth one is the answer. Okay, now see this pathway. In this pathway there are 3 enzymes. Pyruvate dehydrogenase first, E1 is the pyruvate dehydrogenase, E2 is the dihydrolipoyl transacetylase, and E3 is the dihydrolipoyl dehydrogenase. Okay, these are the 3 enzymes, E1, E2, E3. PDH itself is the E1, E2 dihydrolipoyl transacetylase, and E3 dihydrolipoyl dehydrogenase. These are E1, E2, E3 3 enzymes. ऐसे इसके जैसे ही और 2 है. कौन से 2 है? और एक alpha ketoglutarate dehydrogenase and third one is the branch chain keto acid dehydrogenase. Same 3 enzymes, 5 coenzymes. और 5 coenzymes कौन-कौन से है? The first is 5 coenzyme thymine pyrophosphate. This is first. Second, lipoic acid. This is second, lipoic acid. Third one is the coenzyme A. Fourth is the FAD. Fifth is the NAD. See, B1, this is vitamin B1, thymine pyrophosphate B1. This is B2, this is B3, this is B5 and the lipoic acid. So B1, B2, B3, B5 and lipoic acid is required for the pyruvate dehydrogenase complex. How it is regulated? It is regulated, it is active. It is active. This pyruvate dehydrogenase, it is active in the dephosphorylated state, and dephosphorylated state it is maintained by the insulin. So insulin will favor this pyruvate dehydrogenase. The substrate means pyruvate will stimulate the pathway, while the products, for example acetyl coenzyme A, NADH, acetyl coenzyme A and NADH will inhibit the pathway. Okay, this is how the pyruvate dehydrogenase complex is regulated. So E1, E2, E3 and the 5 coenzymes, thymine pyrophosphate, FAD, NAD, coenzyme A and lipoic acid. These are the 5 coenzymes for the pyruvate dehydrogenase complex. Now the next question, Just wait. Now the next question is sodium fluoride present in the fluoride bulb is an inhibitor of enzyme. Here this is the fluoride bulb, sodium fluoride bulb. It has sodium fluoride potassium oxalate in the ratio of 1:3. And these bulbs, the fluoride bulb, it is used for collection of blood sample for the glucose estimation, for the glucose estimation. Okay. So it inhibit the enzyme enolase of the glycolysis and maintain the glucose level in the collected sample. Maintain the glucose level in the collected sample. Inhibit the enzyme enolase by non-competitive irreversible inhibition. Which mechanism? Non-competitive irreversible inhibition. So this is the mechanism of action of the fluoride. What are the other inhibitors of glycolysis? It is the iodoacetate and the arsenate. This inhibits the glyceraldehyde 3-phosphate dehydrogenase enzyme. Now what is the order of draw while collecting the blood sample? Remember, initially it is the blood culture tube. Initially it is blood culture tube. Then after the blood culture it is a citrate blue citrate tube. Citrate tube, blue cap is the citrate tube. Then the red cap, that is the plain tube for the serum chemistry parameter. For the serum chemistry parameter, red tube. After red, golden yellow can be there also. Yellow can be there, which is also used for the chemistry parameter. Then after this, then green is there. Green is there, that is lithium heparin. Lithium heparin. Heparin tube. Then next one is the EDTA, that is the purple. Purple, that is EDTA tube for the CBC. And then the fluoride is the last. Fluoride. So remember, fluoride is the last in the order of draw. Fluoride. First is the blood culture tube, then the blue citrate tube for the coagulation profile, then red tube, red or red and yellow, golden yellow for the serum chemistry parameter, then the green for lithium heparin tube, then the purple EDTA tube, and then fluoride. This is the order of draw while collecting the blood sample. This is again a very, very important question for the FMGE examination. Which of the following can be found in the synovial fluid? So this is very simple question. So synovial fluid, here answer is hyaluronic acid. Answer is hyaluronic acid. So what is distribution? Distribution of hyaluronic acid. So hyaluronic acid, it is distributed in the synovial fluid, vitreous humor of the eye. Then hyaluronic acid, it is important for the shock absorber. Shock absorber, it is a lubricant. Also it is important in cell migration during the morphogenesis and embryogenesis. It is important for the wound repair. Remember, whenever there is wound repair, think about the three things. One is the vitamin C, second is the zinc, and third one is the hyaluronic acid. Zinc, just wait. Zinc, vitamin C, and hyaluronic acid, wound repair. Okay. Now dermatan sulfate, it is present in the skin, it is present in the eyeball, it is important in the sclera, it is also important in the cornea, it is important in the blood vessel walls, it is important in maintaining the structure and shape of this tissue. Keratin sulfate, it is present in the cornea, it is important for the transparency of the cornea. Chondroitin sulfate, it is present in the bone, tendon, and cartilage, and it is important in the shape and structure of the cartilage, bone, and tendon. Okay, along with the hyaluronic acid, is it important as a shock absorber in the weight bearing joint. It is important along with the hyaluronic acid. Now see this hyaluronic acid. Remember, here two important MCQs. All glycosaminoglycan contain uronic acid except keratin sulfate, where there is no uronic acid, there is galactose in the keratin sulfate. And second, dermatan sulfate contain L-iduronic acid. Dermatan sulfate contain L-iduronic acid, which is a epimer of the glucuronic acid. Okay, which is a epimer of glucuronic acid. Now see, hyaluronic acid, the composition. So those who started with the H, the keratin sulfate is the complete exception. Those who started with the H, it has the N, it has the glucose, it has the amino sugar glucose, N-acetyl glucosamine. is there in the hyaluronic acid and D-glucuronic acid. Synovial fluid, vitreous humor of the eye and the skin. Lubricant, shock absorbent, cell migration, and wound repair. These are the functions of hyaluronic acid. Chondroitin sulfate, bone, tendon, cartilage, it is present. Chondroitin sulfate, it is important in maintaining the shape and structure of these tissues. It is important for compressibility of cartilage in weight bearing joint. Compressibility of cartilage in the weight bearing joint along with the hyaluronic acid. Then dermatan sulfate, it contains L-hyaluronic acid. It is present in skin, walls, and sclera. It is important for shape and structure of these tissues. Then heparin, it is oral anticoagulant, also causes release of lipoprotein lipase. For the release of lipoprotein lipase, heparin is required. Then heparan sulfate, it is very, very important. It has many functions. It is present in the glomerular basement membrane. It is present in the synaptic vesicles. It acts as a receptor. It acts as a receptor. See, it is important for the negative charge of the glomerular basement membrane. Then it is important for attachment of lipoprotein lipase to the capillary endothelium. It acts as a receptor and participates in cell adhesion and cell-cell interaction. Cell adhesion and cell-cell interaction, heparan sulfate. Keratin sulfate, it is important in transparency of cornea and it has galactose. There is no uronic acid in the keratin sulfate. So this is all about the glycosaminoglycans. Okay. Now the next, see, a young child presented with history of rashes around the eyes and the mouth. Mother also complains of impaired night vision in the patient and the complaints that the child fall down last month and the wound healing is not proper. मैंने क्या बोला था, जब भी wound healing आएगी, so think about the vitamin C, think about the zinc, think about the hyaluronic acid. Okay, there is rash around the mouth and eyes. So this is a case of acrodermatitis enteropathica, where dermatitis involving the mouth, nose, toes, perineal area. And this zinc is also required for maintaining the vitamin A level in the serum. It is required for the production of retinal binding protein. So it is important. So there is impaired night vision. This is because of vitamin A deficiency also. Okay. Because of zinc deficiency, it affects the vitamin A level in the serum. And defective wound healing is there. So it is a case of zinc, acrodermatitis enteropathica, deficiency of the zinc, that causes defective wound healing, alopecia, dermatitis involving the acral part of the body. Okay. A 13-year-old boy reported with jaundice, fatigue, muscle stiffness, tremor, and behavioral changes. Examination revealed an enlarged liver and spleen, and KF ring was noted. Fisher ring was noted. What is probable diagnosis? This is a clear-cut case of Wilson's disease. Clear-cut case of Wilson's disease. Here there is KF ring, Fisher ring, which is a golden brown or yellow color ring around the cornea in the decimate membrane of the cornea. Also, when the copper deposited in the lens, it causes sunflower cataract. In Wilson disease, because of mutation in ATP7B, which is important for the incorporation of copper into the ceruloplasmin. Also, it is important for the excretion of copper from liver to bile. Because of defect in this ATP binding cassette transporter, that is ATP7B, because of mutation in the Wilson disease, there is copper deposition occurs in the brain, particularly in the lenticular nucleus of the brain, that is known as hepatolenticular disease, degeneration. Okay, lenticular nucleus of the brain, and liver is involved here in the Wilson's disease. So decrease in the ceruloplasmin level occurs in the Wilson's disease. Also, copper accumulation occurs in the Wilson disease. Menkes disease is the copper deficiency. There is brittle hair, kinky hair, and along with these, there is mental retardation in the Menkes disease. Acrodermatitis enteropathica is the zinc deficiency, and tetany is due to the calcium deficiency. So, KF ring in the cornea, it is a feature of the Wilson's disease. See, this is ATP7A, means ATP binding cassette transporter protein 7A, and this is 7B. 7B is required for copper excretion in bile from liver to bile, and incorporation of copper into the ceruloplasmin. So this is defective in the Wilson's disease, while in the Menkes disease there is defective absorption of the copper from the intestine. So there is decreased copper level that causes the affect the copper dependent enzyme. For example, lysyl oxidase, it is involved. Lysyl oxidase is defective in the Menkes disease, and also there is, so in Menkes disease there is mental retardation, and there is hypopigmented patches all over the body, and there is brittle hair, brittle kinky hair in the Menkes disease. This affects the male because it is X-linked disease. Okay, and Wilson is the autosomal recessive condition. Now coming to the next, just wait. Sir, all topics covered today biochemistry. It is not possible to cover all topics in this session, but there is session available that is by the name FMGE Sprint in the on the Meded channel. Also, there is two complete session. Complete means 3+5 hour session on the FMG on the Meded channel. So you can watch that also. Okay. So a 7-year-old child came with complaint of excessive fatigue and muscle pain. See, there is muscle involvement. See, here hint is muscle involvement. After playing in the school, blood investigation were done immediately after the exercise, and results shown low glucose and lactate level. Low glucose and lactate level. What is the most probable diagnosis in this child? So here the glycogen storage disorders are given. Okay. Remember, the von-Gogg's disease is the important disease, the common disease, glycogen storage disorder, but it does not involve the muscle. Muscles are not involved in the von-Gogg's disease because it is due to the defect in glucose 6 phosphatase. So glucose 6 phosphatase, it is muscle, it is absent in the muscle. Just wait. Glucose 6 phosphatase, it is absent in the muscle. Glucose 6 phosphatase, it is absent in the adipose tissue. So the muscles are not involved in the von Gogg's disease. Also, splenomegaly is not there in the von Gogg's disease. Okay, and here the muscle involvement is there. So muscle involvement is there in the McArdle disease, there in the Cory's disease, also in the Pompe's disease. But if there is question on the Pompe's disease, there will be comment. अगर ये Pompe's disease पे question रहेगा तो यहाँ पे heart पे जरूर comment रहेगा cardiomyopathy, cardiomegaly करके. So because it is a typical feature, along with the diminished muscle tone, there is hypotonia or diminished muscle tone in the Pompe's disease. Pompe's disease, their life expectancy in Pompe's disease is only 18 months to 2 years. Pompe's disease because of lysosomal acid maltase. There is involvement of muscle, there is involvement of the liver in the Pompe's disease. So it is severe condition. There is no involvement of heart in this case, clinical cases. So this is ruled out, this is ruled out. Now McArdle and Cory's disease. Now if there is question on the Cory's disease, there must be a hint about the SGOT, SGPT level and progressive liver cirrhosis in the Cory's disease. This is due to the debranching enzyme defect. But here only muscles are involved. That to low lactate level that indicates the that rule out the von Gogg's disease. In von Gogg's disease there is lactic acidosis. So this is a case of McArdle disease, muscle involvement. Exercise intolerance, muscle involvement is there. In the McArdle disease there is second wind phenomenon. Means if you take rest for some time, you can resume your activity in the McArdle disease. Also, if you prolong your exercise or prolong your tasks, in that case, because of rhabdomyolysis, the burgundy color urine will be there in the McArdle disease. So this is a case of McArdle disease due to defect in the enzyme, decreased activity of muscle glycogen phosphorylase. Muscle glycogen phosphorylase defect. Muscle glycogen phosphorylase defect. Now see, type 0, it is glycogen synthase defect. There is no hepatomegaly. Hypoglycemia is there in between the meal. This is severe condition and life expectancy is very less in glycogen synthase defect. Second, type 1A is the von Gogg's disease. Type 2B is the second type of the von Gogg's disease. Okay. In the type 1A von Gogg's disease, that is deficient enzyme is glucose 6 phosphatase, while type 2B there is transporter defect. transporter of glucose 6 phosphate is defective in the type 2B disease. So what are the symptoms of glycogen storage disorder, von Gogh disease? There is hypoglycemia, there is fasting hypoglycemia, there is liver involvement, there is renal involvement, kidney enlargement is there. So there is hepatoreinomegaly, protuberant abdomen, three in extremities, doll-like faces, along with the hypoglycemia, lactic acidosis, hyperuricemia, increased uric acid level, hyperlipidemia is there. Lipids are also raised. Uric acid levels are also raised. This is because of diversion of glucose 6 phosphate to the HMP pathway. That's why uric acid levels are raised, and also diversion of glucose 6 phosphate for the lipid synthesis. That's why cholesterol TG levels are also raised in the von Gogh disease. Along with this, there is lactic acidosis in the von Gogh disease. This is hepatic glycogen storage disorder, von Gogh disease. Now Pompe's disease, this is due to the some glycogen, it is degraded by the lysosomal enzyme acid maltase. Whenever there in the newborn, in the infant, and up in the early childhood, it is important. So acid maltase defect, deficiency of acid maltase, it causes the Pompe's disease, and it involves liver, it involves the liver, it involves the muscle, it involves the heart. Particularly, death of the child occurs due to the heart failure in the Pompe's disease. There is hypotonia, there is diminished muscle tone, there is floppy infant, diminished muscle tone, and cardiomegaly is there, cardiomyopathy is there, and due to heart involvement, early death occurs in the Pompe's disease. Type 3 is the Cory's disease. Remember, A, B, C, D, C, D, D branching enzyme. Cory's disease, D branching enzyme defect. Anderson, AB. Okay, this is AB. Anderson disease, this is branching enzyme. Cory's disease, D branching enzyme defect. In this defect, see, Cory's disease, D branching enzyme defect, there is progressive liver cirrhosis, there is increased SGOT, SGPT level, there is involvement of liver, there is involvement of muscle in this both Cory's disease and Anderson disease. Okay, and McArdle's disease, there is muscle involvement because of deficiency of enzyme muscle phosphorylase, and there is exercise intolerance. This is the typical feature, and glycogen accumulates in the muscle. Then Her's disease, there is liver glycogen phosphorylase defect, there is hepatomegaly and fasting hypoglycemia in the Her's disease. Of this one is important. McArdle is important. McArdle is important, and von Gogh is important. Now this is again important question, how the glycogen phosphorylase levels are regulated. Just wait 1 minute. See, glycogen phosphorylase, the role, glycogenolysis. Glycogenolysis means conversion of glycogen into the glucose. Now glycogen is converted into glucose by the glycogen phosphorylase enzyme. So what are the allosteric activators of glycogen phosphorylase? Remember this calcium. This is very, very important. Calcium, which is released from the muscle during the exercise, is the allosteric activator of glycogen phosphorylase, and it directly activates the phosphorylase kinase without involvement of protein kinases. Without involvement of protein kinases, it activates the phosphorylase kinase, which activates the glycogen phosphorylase. So calcium role is there in the activation of glycogen phosphorylase, while glucose 6 phosphate and glucose inhibit the glycogen phosphorylase. So glycogen phosphorylase, it is regulated by glucagon. Glucagon increases the glycogen phosphorylase level by the phosphorylation. So it is active in the phosphorylated state. Glucagon increase the conversion of glycogen into glucose, while insulin inhibit the conversion of glycogen into glucose. Insulin favors the dephosphorylated state, glucagon favors the phosphorylated state. Apart from this, calcium is the allosteric activator of the glycogen phosphorylase. So remember, calcium and AMP, these are the activators of the glycogen phosphorylase. This is again now repeated topic in number of examination, NEET PG, FMGE, INICET exam. Which of the following will be required as a coenzyme in the de novo synthesis of fatty acid? Remember, de novo synthesis of fatty acid, the regulatory enzyme is acetyl coenzyme carboxylase, which converts the acetyl coenzyme A. Acetyl coenzyme A is converted into malonyl coenzyme A. This is carboxylation reaction where ATP, biotin, ABC, CO2. ATP, biotin and CO2 is required, and here enzyme is acetyl coenzyme carboxylase. Apart from this, fatty acid synthase complex is required, which has many reductase enzyme. So reductase mainly requires the NADPH. Reductase mainly requires the NADPH. So here answer is NADPH. But this acetyl coenzyme carboxylase, there are 5 cofactors required. 1, 2, 3. ATP, biotin, CO2 are bicarbonate, and then manganese and the NADPH. It is required as a NADPH. These are the cofactor, 5 cofactors required for the acetyl coenzyme carboxylase enzyme. Okay. So here too, it is a bifunctional enzyme. It has carboxylase activity and transferase activity. Carboxylase and transferase activity. So ATP, biotin, CO2, manganese and NADPH is required for the acetyl coenzyme carboxylase. It is a regulatory enzyme regulated by CID. Okay. C means citrate. Citrate stimulate this pathway. Then insulin stimulate this pathway, and insulin will favor the dephosphorylated state of the enzyme. So citrate, insulin and dephosphorylated state of the enzyme, it is active. Acetyl coenzyme carboxylase required 5 cofactor: ATP, biotin, CO2, manganese and NADPH. Also various reductase, 2 reductase are there in the fatty acid synthase complex which requires NADPH. So here answer is NADPH. Okay. Carboxylation reaction requires biotin. Black urine in infancy is diagnostic of alkaptonuria. Alkaptonuria, it is homogentisate oxidase defect where alkaptone deposits in the various tissue occurs. Also it is excreted in the urine, and when urine is exposed to the air, after some time urine turns into the dark color. So this is a case of alkaptonuria. Phenylketonuria, there is mousy odor of urine, and in phenylketonuria, phenylalanine hydroxylase is deficient, and because of that phenylalanine is diverted for phenyl lactate, phenyl acetate, phenyl pyruvate, phenylacetyl glutamine, and this product, particularly the phenyl acetate, gives the mousy odor. As phenyl pyruvate is excreted in the urine, it is keto acid, that's why the name is phenylketonuria. Maple syrup urine disease, there is burnt smell, sugar, because this is a branch chain keto acid dehydrogenase deficiency. And homocystinuria, there is cystathionine beta synthase defect in which there is ectopia lentis occur, subluxation of lens occur, mental retardation is there in the homocystinuria. So here this is a case of alkaptonuria. It is asymptomatic in the childhood, but as the age advances, the chronic arthritis will be there because of deposition of alkaptone in the joints. Patient came to the hospital with complaint of abdominal pain. Routine investigation were unremarkable. On observation, the urine turned black on standing. Which of the following enzyme is likely to be defective in this patient? So this is defect, that is homogentisate oxidase. It converts homogentisate acid. Homogentisate is converted into 4-mallyl acetoacetate by the enzyme homogentisate oxidase. And if there is defect in this homogentisate oxidase, this is diverted. This is diverted for the benzoquinone acetate, and on polymerization, it will give the alkaptone. It gives the pigment alkaptone that causes ochronosis. That is black color deposition of various cartilages, sclera, tendons, ochronosis. Also there is black color urine on exposure to air, but this condition is asymptomatic in the childhood, but as age advances there is tendency to develop arthritis. High thermic effect will be exhibited by following food type. So high thermic effect or the specific dynamic action or calorogenic action of the food, it is because of the protein. What do you mean by SDA, or the thermic value of the food or the calorogenic action of the food? It is a extra amount of heat which is required for the which is required for the generally in case of protein it is required for the deamination, it is required for the transamination, it is required for the urea cycle, it is required for the synthesis of various proteins. It is required, so extra amount of heat which is required for use of this foodstuff is known as the specific dynamic action or high thermic value. It is 30% in case of the protein, while carbohydrate it is 5 to 10%, while fat it is less than 5%. Less than means 0 to 5%. In case of fat, in case of carbohydrate 5 to 10%, protein it is 30%, mixed diet it is 10%. So this is known as specific dynamic action. While calculating the energy requirement of an individual, three things are important. First is the BMR, basal metabolic rate. Second is the specific dynamic action of the foodstuff, and third one is the physical activity, energy required for the physical activity. So these are the three important points. Just wait. So these are the three important points which are important. Okay. Now see this table. This is very, very important table. So this is SDA, thermic action or calorogenic action of the foodstuff. For a carbohydrate it is 5 to 10%, for lipid it is 0 to 5%, protein it is 30%, it is maximum for the protein. It is thought to be required for the transamination, deamination, urea cycle and the protein synthesis it is required. Okay. Now the mixed diet it is 10%. For the mixed diet it is 10%. The calorific value or caloric value, not calorific, it is caloric value, means energy given by the foodstuff. It is 4 calorie for the carbohydrate, 9 calorie for the fat and 4 calorie for the protein. While the RQ, respiratory quotient, means CO2 consumed, means CO2 produced to O2 utilized ratio for the given foodstuff is known as RQ, respiratory quotient, means CO2 produced, ratio of CO2 produced to the O2 consumed. It is known as the RQ, respiratory quotient. For the carbohydrate it is 1, for the lipid it is 0.71 and for the protein it is 0.81, 0.81, and for the mixed diet it is 0.85. That is known as respiratory quotient of the food. So this chart is very, very important. This SDA and the respiratory quotient, it is important. Now the most abundant amino acid found in collagen. Collagen is it is 3 amino acids. They are important in the structure of collagen, that is glycine XY. So here answer is the glycine. The 30% is the glycine. This is smaller amino acid and which is very, very important in the turn in the collagen. For the helix formation in the collagen, it occupies the small space, glycine. 30% it is glycine. It is glycine XY. So glycine, proline, hydroxyproline, glycine, proline, hydroxyproline, glycine XY. Mainly X is proline, Y is hydroxyproline. So glycine XY is the important, followed by the lysine is important in the structure of the collagen. It is a triple helical structure with quarter staggered arrangement is there in the collagen, and two important means one vitamin and one mineral which take part in the collagen synthesis, that is vitamin C and the copper. These are the two important one vitamin and one mineral which is important in the collagen synthesis and strengthening the collagen. These are important. Vitamin C, it is required for the hydroxylation of lysine, hydroxylation of proline by the lysyl hydroxylase and prolyl hydroxylase. It causes the hydroxylation of peptidyl lysine and peptidyl proline. So it is a post-translational modification because it occurs in the peptide chain. So prolyl hydroxylase and lysyl hydroxylase, these are important enzyme which are vitamin C dependent hydroxylation reaction. That's why in the collagen synthesis, the vitamin C has the important role. It gives rigidity to the collagen molecule. While the crosslink, collagen crosslinks are there, and because it is between the aldol of the lysine and hydroxylysine. Lysine and hydroxylysine, the aldol crosslinks are there, interchain, intrachain crosslinks are there, and these are because of the formation of aldol compounds and because of the because of the lysyl oxidase. This is because of the action of the lysyl oxidase enzyme, and this lysyl oxidase enzyme is dependent on the copper. So collagen strengthening, cross-linking the copper is important. Formation of collagen, rigidity of the molecule, it is given by the vitamin C. Hydroxylation, vitamin C is important, and the lysyl oxidase is important for the cross-link formation. So this is the role of these two compound in the collagen synthesis. Okay. Now, the various disorders, various types of collagen is there. So type 1 collagen is defective in the osteogenesis imperfecta. There is different disorders and that can be asked, that is Ehlers-Danlos syndrome. Also the epidermolysis bullosa is there. So the different collagen disorders are there, in which the various types of collagen, they are defective. Now DNA packaging is done by which of the following? Here answer is histone. Histone is important. H1, H2A, H2B, H3, H4. So these are the 5 histones. These are the positively charged compound, contain the positively charged amino acid, histone, lysine, arginine, and they reacts with the negatively charged DNA in the major and minor grooves, and they helps in the DNA packaging. They helps in the DNA packaging, that is known as organization of DNA. Also histone modification is there in the epigenetic mechanism. Just remember, in the epigenetic or the modification or the regulation of gene expression, just remember 2 things. Acetylation of histone, acetylation will activates the gene. A for A activates the genes, while methylation mutes or methylation, it inactivates the gene, inactivates the gene. Just remember these 2 epigenetic modifications. Now see, epigenetic modification means without altering the nucleotide sequence. So DNA packaging is done by which of the following? Here answer is the histone. These are the basic proteins, nucleoproteins. This is the histone structure. This is the histone octamer, which is composed of H2A, H2B dimer and tetramer of H3 and H4. So total 8 molecules are there. This is around this histone octamer, the DNA wrapped near about 1.75 superhelical structure of DNA, which is wrapped around the histone protein. It contains near about 145 base pairs of the DNA. Base pairs of DNA in this structure, superhelical structure. 1.75 ton of DNA, which includes 145 base pair in this, and it is at the entry point and the exit point, this DNA molecule is interacted with the H1 histone, and this spans about near about 30 base pair of the DNA. So this is histone octamer. This is H1. In the octamer, there is H2A, H2B, H3 and H4, and it helps in the organization of DNA. So there is, in the organization of DNA, there is end-to-end 10 to the power 4-fold decrease in the length of the DNA. 10 to the power 4-fold decrease in the length of DNA. So 2 nanometer DNA, it is converted into 10 nanometer fiber, which is converted into 30 nanometer fibril. Okay, 30 nanometer fibril, which gives the 300 nanometer non-condensed loop, 700 nanometer condensed loop, and 1400 nanometer metaphase chromosome. So naked helical DNA 2 nanometer, the bits on string appearance 10 nanometer fiber, bits on string appearance because of the nucleosome, and the nucleosome 6 to 8 nucleosomes are there. They form the 30 nanometer chromatin fibril, which is converted into 300, 700 non-condensed loop, condensed loop associated with nuclear scaffold proteins, and 1400 nanometer DNA, organized DNA into metaphase chromosome. So histone proteins, by reacting with major and minor grooves, they interact with the DNA and they helps in the organization of DNA. So there are various post-translational modification in the histone proteins that includes the ribosylation, ubiquitinylation, phosphorylation, acetylation and methylation. Okay, sumoylation. So these are the post-translational modification in the histone proteins. The next is, what mechanism is seen in xeroderma pigmentosum? Xeroderma pigmentosum. So it is a defect. Xeroderma pigmentosum is the condition in which there is multiple freckles on the sun exposed part of the body, and that is due to thymine pyrimidine dimer formation. This is due to UV light induced thymine dimer formation. UV light induced thymine dimer formation, and because of defective nucleotide excision repair, because of UV light thymine lesion and defect in the nucleotide excision repair, there is disease that is known as xeroderma pigmentosum. The precancerous condition, xeroderma pigmentosum, multiple freckles on sun exposed part of the body. Now it is repaired by the nucleotide excision repair. If it is defective, it causes xeroderma pigmentosum. So lot of diseases are there related with this. So this chart is very important. This chart is very important for any examination, any entrance examination. See, there are 4 to 5 basic types of DNA repair mechanism. One is the mismatch repair, when the base is incorrect base is added while the when the replication is going on, or the insertion or deletion mechanism because of the replication error. If there is mismatch base is added, incorrect base is added, it is repaired by the mismatch repair mechanism. It is repaired by the mismatch repair mechanism. And there are 4 basic steps in the repair mechanism. First is the recognition. कहाँ पे damage हुआ वो recognize करना है, ठीक है. First one is the recognition of that. Okay. Then removal. Okay. First is the recognition, then there is removal, then there is synthesis, and then there is ligation. Recognition, removal, synthesis, and ligation. So recognition is done by some proteins or some enzymes. Then removal is with the endonuclease activity, removal is done. Then the synthesis is done by the DNA polymerase, and the ligation by the DNA ligase. Now see, mismatch repair. If there is defect in the mismatch repair, it is repaired by the if there is defect in the mismatch repair, it causes the disease that is known as HNPCC, hereditary non-polyposis colorectal cancer. So this is important here, hereditary non-polyposis colorectal cancer in the defective mismatch repair. Okay, also known as Lynch syndrome. If because of reactive oxygen species or the free radical or by the alkylating agent, if there is creation of a basic site, means on the base is not added there, only sugar is there and phosphate is there. So when there is a basic site, means nitrogen base is not attached. So in that case, it is repaired by the base excision repair, and defect in the base excision repair, it causes mute YH associated polyposis. This is not important, don't remember this. Remember this, hereditary non-polyposis colorectal cancer. Now, if due to UV light or the chemical, there is pyrimidine dimer formation, thymine dimer formation, or thymine crosslink is there, this bulky lesion, it is repaired by the nucleotide excision repair. And if there is defect in nucleotide excision repair, it causes xeroderma pigmentosum or Cockayne syndrome, another disease. This is xeroderma pigmentosum. So this is important. Okay. Now if there is double strand break or single strand break or interstrand or intrastrand crosslink is there, this type of defect, when there is ionizing radiation or X-ray or anti-tumor drug, causes this type of defect in the DNA. This is repaired by the non-homologous end joining. This is the most common. Most common is the non-homologous end joining, or by the homologous recombination by using the sister chromatid and similar part of the chromosome. The homologous recombination is done. Okay. So if there is defect in the homologous recombination, it causes these disorders. Particularly remember the ataxia telangiectasia like disorders, or Bloom syndrome, or the breast cancer susceptibility. This is important. This is newly added in the new edition. So this is related with the homologous recombination. If there is defect in the non-homologous end joining, which requires the 𝐾𝐝 protein, ATP and DNA dependent kinases, they are required for the non-homologous end joining, and defect in the non-homologous end joining will cause the severe combined immunodeficiency. So here the 3 part should be remembered. Just the defect in the mismatch repair causes the hereditary non-polyposis colorectal cancer or Lynch syndrome. Defect in nucleotide excision repair causes xeroderma pigmentosum, and defect in the double strand break repair, that is homologous recombination, it causes the breast cancer susceptibility. Also non-homologous end joining, it causes the severe combined immunodeficiency. This was the first disease for which the gene therapy was tried, adenosine deaminase deficiency, SCID, severe combined immunodeficiency. Next question. A 17-year-old boy diagnosed with diabetes brought to the hospital in semi-conscious state and abnormal deep rapid breathing. This is known as cosmol breathing. Diabetic की case है. His plasma glucose was 673 milligram per deciliter and urine shows positive Benedict and Rothras test. See, Benedict test is positive, Rothras test is positive. अगर ये दोनों टेस्ट पॉजिटिव है तो गो विद द डायग्नोसिस ऑफ डायबिटिक कीटोएसिडोसिस. इट इज ए केस ऑफ डायबिटिक कीटोएसिडोसिस. नाउ ब्लड इन्वेस्टिगेशन रिवील्ड फॉलोइंग रिजल्ट. ब्लड पीएच इज 7.21 means decrease in the blood pH means acidosis is there. PCO2 is 30, normal level is 35 to 45, so it is decrease in the PCO2, and the bicarbonate is 16 millimole per liter. So bicarbonate normal level is 22 to 28 millimole per liter, so it is decreased. So this bicarbonate component is going with the pH. So the parameter which is with the pH, here is the acidosis, here is the acidosis. So those who is with means those who goes with the pH is the primary defect. So here is the metabolic acidosis. Now here the PCO2 means carbonic acid. If acid decreases, it is alkalosis. There is decrease in the acid. Okay, so it is not going with the pH. So it is a compensatory mechanism. Those who goes with the pH is the primary defect and another is the compensatory mechanism. So it is a case of metabolic acidosis with compensation. Actually, this is a case of diabetic ketoacidosis. See, this is a case of metabolic acidosis with compensation, but here there is no mention. So here option A is correct. Metabolic acidosis with compensation. Now what happens in the diabetic ketoacidosis? In diabetic ketoacidosis, there is high anion gap metabolic acidosis. In diabetic ketoacidosis, there is production of ketone bodies. So ketone bodies means beta hydroxybutyric acid. Acetic acid means acetoacetate, beta hydroxybutyrate and acetone. These are produced. Now these ketone bodies, they are acidic in nature, and to neutralize these ketone bodies, this bicarbonate is utilized. This bicarbonate is utilized to neutralize the ketone bodies. That's why there is acidosis. And this is compensatory mechanism, abnormal deep rapid breathing. This is cosmol respiration, deep rapid breathing, to blow out the CO2. CO2 का concentration कम करना है ताकि बाइकार्बोनेट और कार्बोनिक एसिड का रेशियो मेंटेन रहे. बाइकार्बोनेट और कार्बोनिक एसिड का रेशियो जो है, जो 20:1 है, वो मेंटेन रहे. उसके लिए ये compensatory mechanism. Why there is semi-conscious state? Because of the dehydration, because of the acid-base disorder. So this is a case of metabolic acidosis. Now see, there are three buffer system in the blood: bicarbonate, phosphate and the protein. This is the major buffer in the extracellular fluid, bicarbonate buffer, and alkali reserve. It is very, very important. It is in the ratio 20:1. Bicarbonate level is much more in our body, 22 to 28 millimole per liter. So high bicarbonate concentration. This is because why bicarbonate buffer is important, because alkali reserve, that is high concentration of bicarbonate. And second, the parameters here in the bicarbonate buffer, they are under the physiological control, that is CO2 by the lung and bicarbonate by the kidneys. Phosphate buffer, it is major intracellular buffer. It is the potent buffer and it is intracellular buffer. And third one is the protein buffer. So these are the three important buffers present in the blood. Now see, this is how to diagnose the case. Now see, pH 7.35 to 7.45. The 22 to 28 is the bicarbonate normal, and 35 to 45 is the PCO2, partial pressure of CO2 is the normal. First see whether it is acidosis or alkalosis. अगर pH कम है तो acidosis, pH ज़्यादा है तो alkalosis. ये तुम्हारा primary defect है, pH वाला. pH कम है तो acidosis, pH ज़्यादा है तो alkalosis. ठीक है, 7.35 से कम है तो acidosis, 7.45 से ज़्यादा है तो alkalosis. This is the first. Then look for the bicarbonate. It is 22 to 28 is the normal. If it is below 22 means alkali reserve. Bicarbonate क्या है? Alkali है. Alkali अगर कम हो गया, that means it is acidosis. If it is below 22, it is acidosis. If it is above 28, it indicates the alkalosis. ठीक है. If PCO2 means dissolved carbonic acid. Carbonic acid. If PCO2 is more, it is acidosis. Means acid is more means it is acidosis. If PCO2 is less, it is alkalosis. अभी ये देखना है कि इसके बाद में those who goes with the pH, जो pH के साथ जाएगा वो primary defect and another is the compensatory mechanism. So this is how we can diagnose the acid-base disorder. And these are the causes of metabolic acidosis, alkalosis, respiratory acidosis, respiratory alkalosis. Okay. In the metabolic component, the bicarbonate is important. Bicarbonate level decreases in metabolic acidosis. Bicarbonate level increases in metabolic alkalosis. In the respiratory acidosis, alkalosis, the PCO2 is important. If PCO2 मतलब carbonic acid increase हो गया तो respiratory acidosis, carbonic acid decrease हो गया तो respiratory alkalosis. These are the causes. Now see, this is again important, very, very important case for FMGE examination. A baby refuses breast milk since second day of birth, refuses breast milk, vomits on forceful feeding but accept glucose water, develops diarrhea on third day. By fifth day, she is jaundiced with liver enlargement and eyes shows cataract, that is oil droplet cataract. Oil droplet cataract. Urinary reducing sugar was positive, but blood glucose estimated by the glucose oxidase method was found low. The most likely cause of the deficiency is. Now see, baby refuses breast milk since second day of birth, omits on forceful feeding, okay, accept glucose water, develops diarrhea on the third day. There is jaundice with enlargement, liver enlargement, and eyes show cataract. Oil droplet cataract is a typical feature of galactosemia. This is Benedict test positive, but the plasma glucose is low. That means Benedict test is positive because of galactose excretion in the urine. Because of galactose reducing sugar, Benedict test is for the reducing sugar, because GOD POD method measures the D glucose only, beta D glucose only. So it is galactosemia because of defect in galactose 1-phosphate uridyl transferase. Galactose 1-phosphate uridyl transferase, this is a cause of classical galactosemia. There is opacity in the lens because of accumulation of dulcitol or galactitol in the lens. Dulcitol. In the galactosemia, see, in the galactose metabolism, galactose is converted into galactose 1-phosphate, and galactose 1-phosphate is converted into UDP galactose, which is converted into UDP glucose. UDP galactose is converted into UDP glucose. Now this is the enzyme here. This is the important enzyme. If it is defective, it causes the galactosemia, that is classical galactosemia. Galactokinase, here is the galactokinase. And this is epimerase enzyme. Okay, this is asymptomatic. This causes only congenital cataract. Now this is classical galactosemia due to galactose 1-phosphate uridyl transferase defect, and accumulation of galactose 1-phosphate in the tissues causes the hepatomegaly, causes the mental retardation. Mental retardation. This galactose 1-phosphate inhibit the glycogen phosphorylase enzyme that decreases the conversion of glycogen into glucose. So there is hypoglycemia in the galactosemia. And if there is block at this level in the galactosemia, there is block in this galactose 1-phosphate uridyl transferase. So it is diverted. For the production of dulcitol. Another name is galactitol by the aldose reductase. And because of osmotic effect of this galactitol or dulcitol, it causes the cataract. It causes congenital cataract. So this is a case of classical galactosemia. So remember this case. This is a very, very important case for your examination. So a 31-year-old mother delivered a premature baby at 34 weeks of gestation. Baby cried well after the birth. All reflexes were normal, but 3 days after birth, mother observed yellow skin and eyes of the baby. On blood examination, indirect bilirubin. Indirect means unconjugated bilirubin. It is found to be 11 milligram per deciliter. So what is your probable diagnosis? This is a case of physiological jaundice. This is very, very important. Third day of life. If it is within 24 hours, it is pathological condition. If it is after second, third day, it is known as the neonatal physiological jaundice because of rapid hemolysis. Okay, and incapable liver for conjugating the bilirubin. So it is unconjugated bilirubin level increases and phototherapy is given. So this is neonatal physiological jaundice. Now we'll discuss the congenital hyperbilirubinemia. Just wait. So in congenital hyperbilirubinemia, if there is increase in the unconjugated bilirubin means indirect bilirubin, it is because of the Crigler-Najjar type 1 or type 2. Crigler-Najjar type 1, type 2. There is increase in the unconjugated bilirubin. This is increase unconjugated bilirubin in the Crigler-Najjar syndrome. This is due to the deficiency of UDP glucuronil transferase, which is important for conjugation of bilirubin into UDP glucuronate, UDP diglucuronide. Okay. So if there is complete deficiency, it causes the type 1 Crigler-Najjar syndrome, in which the bilirubin goes above 20 and it causes the toxic effect, that is Kernicterus is there in the Crigler-Najjar syndrome. And if it is the only 10%, less than 10% activity is present, less than 10% activity of UDP glucuronil transferase is there, so it causes the type 2 Crigler-Najjar syndrome. In that case, it rarely goes up to 20. It rarely goes up to 20. Gilbert, it is a mild condition in which bilirubin goes up to 4 milligram per deciliter, and near about 30% activity of UDP glucuronic acid is retained here in the Gilbert syndrome. 30% activity near about is retained in the Gilbert syndrome. So Crigler-Najjar type 1, type 2 and Gilbert, this causes the increase in the indirect bilirubin or unconjugated bilirubinemia. While Dubin-Johnson and Rotor, DR, this causes increase in the direct bilirubin, DR, direct bilirubin, Dubin-Johnson, Rotor. Dubin-Johnson is due to mutation in the MRP2, multidrug resistant protein 2, MRP2, which is important in the secretion of bilirubin into bile, which is important for secretion of bilirubin into bile. And there is accumulation of epinephrine metabolite, that's why there is black colored liver. So that is known as, because of metanephrine, because of accumulation of epinephrine metabolite, there is black colored liver. And due to mutation in the MRP2, which is important for secretion of bilirubin, which is a rate limiting step in the bilirubin metabolism. While Rotor syndrome, it is due to mutation in organic anion transporter 1B1 and 1B3. These are the required transporters required for conjugate bilirubin, for the reuptake of conjugated bilirubin into hepatocyte. This organic anion transporter 1B1 and 1B2, 1B3 is required, and defect in this organic anion transporter causes the Rotor syndrome. This is a direct bilirubinemia. There is no black color or no staining of the liver. So these are the 4 disorders: Crigler-Najjar type 1, type 2, Gilbert. There is increase in the unconjugated or indirect bilirubin. Dubin-Johnson, Rotor, there is increase in the direct bilirubin. Now the important, top rated and most important clinical case from the biochemistry for any examination, that is this image. Wrinkled paper, tissue paper appearance of the macrophages. Wrinkled paper appearance on the bone marrow biopsy is a typical feature of the Gaucher's disease. A patient presented with refractory anemia and histological picture is shown with cells in the bone marrow. Which of the following enzyme is deficient? This is the Gaucher's cell. There is intracytoplasmic inclusions. Intracytoplasmic inclusion. This is a Gaucher's cell. It is present in Gaucher's disease because of deficiency of glucocerebrosidase. So because of glucocerebrosidase defect, the glucocerebrosides, they are not converted into the glucocerebroside, they are not degraded into glucose and ceramide. So that's why there is accumulation of glucocerebroside into the macrophages that causes the wrinkled paper, tissue paper appearance of macrophages. And there is involvement of liver, spleen and bone marrow. So as there is bone marrow is involved, it causes the anemia, leukopenia, thrombocytopenia. Also it causes avascular necrosis of the bone. It causes the frequent fractures. And this is the bone marrow biopsy picture, that is wrinkled paper or tissue paper appearance, Gaucher's disease. This is the bone biopsy. See, this is again Gaucher's disease. This is the wrinkled paper or tissue paper appearance of the macrophages. A child presented with difficulty in vision. So here vision is involved. On examination, a cherry red spot on the macula. There was no organomegaly. Identify the disease. Now see, remember, in the lysosomal storage disorder, the cherry red spot on the macula is seen because of the peripheral white and central red is there. Peripheral white is because of deposition of lipids on the retina. And the fovea appears bright, that is known as cherry red spot on the macula. This is a characteristic feature except in the KGF, Krabbe's, Gaucher's, and the Fabry's disease. इनमें cherry red spot नहीं रहता. So on examination there is cherry red spot on the macula. So Gaucher is not answer. Then Gaucher is not answer. Okay. In Hunter disease, the cornea is clear in the Hunter disease. This is mucopolysaccharidosis, and this is not a feature of this Hunter disease, because cherry red spot, it is generally seen in the lysosomal storage disorder. This is MPS, mucopolysaccharidosis, Hunter disease. There is retinal involvement and there is clear cornea, while in Hurler there is cloudy cornea. Now Tay-Sachs and disease and Niemann-Pick disease. Now in Niemann-Pick disease there is hepatosplenomegaly. Along with the cherry red spot on the macula, there is hepatosplenomegaly. This is due to the sphingomyelinase defect. There is hepatosplenomegaly, but there is no organomegaly here in this case. So here this is a case of Tay-Sachs disease because of hexosaminidase. Hexosaminidase defect. So it is a case of Tay-Sachs disease. It is GM2 gangliosidosis, where GM2 means GM2 ganglioside, it is accumulates in the Tay-Sachs disease. So this is a case of Tay-Sachs disease. In the Sandow disease, there is organomegaly along with these features. Now see, again one case. This is a Gaucher's disease. This image is of Gaucher's disease, and this is known as Erlenmeyer flask deformity. ये shape का आपने flask देखा होगा बायोकेमिस्ट्री में, conical flask, Erlenmeyer flask. Erlenmeyer flask deformity. This is a Gaucher's disease. Involvement of bone is there. Now see, this is cherry red spot. The retina appears bright, and the peripheral, there is because of peripheral deposition of lipid. The following fundoscopy depict a characteristic finding. This finding is present in all of the following except, so it is not seen in KGF, Krabbe's, Gaucher and Fabry's disease. So here answer is Gaucher's disease. So do the Gaucher's properly. It is involvement of liver, spleen, bone marrow. There is pancytopenia, means leukopenia, thrombocytopenia. Because of thrombocytopenia, bruising tendencies will be there. Thrombocytes means platelet. Leukopenia, anemia is there, refractory anemia, not responding to treatment, frequent fracture because of the avascular necrosis, and there is bone involvement, Erlenmeyer flask deformity, there is tissue paper or wrinkle paper, appearance of the macrophages. There is no involvement of the retina or the no cherry red spot on the macula in the Gaucher's disease, and rarely there is mental retardation in the Gaucher's disease. And this is intracytoplasmic inclusion bodies. Niemann-Pick disease, there is hepatosplenomegaly. Tay-Sachs disease, there is no organomegaly, but vision is involved here. Sandow disease, it is the advanced version of Tay-Sachs disease, and here organomegaly is there along with the feature of Tay-Sachs disease. So these are the lysosomal storage disorders. Lysosomal storage disorder, Gaucher's disease, it is due to defect in beta glucosidase or glucocerebrosidase. There is accumulation of glucocerebroside. Niemann-Pick disease, it is sphingomyelinase defect. There is accumulation of sphingomyelin. Krabbe's disease, it is beta galactosidase defect. Galactocerebrosides accumulated. Fabry's disease, it is there is alpha galactosidase defect, and in Fabry's disease there is skin lesions, skin rash, skin lesions or red spots are there, that they are known as telangiectatic lesion, and this is a X-linked disease. Fabry's disease is the X-linked disease. Tay-Sachs disease, it is due to hexosaminidase A defect, and Sandow disease due to hexosaminidase A and B. So these are the lysosomal storage disorders. Now identify the enzyme X targeted by allopurinol. Identify the enzyme X targeted by the allopurinol in the picture given below. So it acts on the xanthine oxidase. Here answer is xanthine oxidase. By the competitive inhibition, also by the suicidal inhibition, competitive and suicidal inhibition. By competitive inhibition, allopurinol inhibit the xanthine oxidase enzyme, which is important in the conversion of hypoxanthine to xanthine and xanthine to uric acid. This is competitive inhibition. In the suicide inhibition, this allopurinol is converted into alloxanthine, and alloxanthine is the more powerful inhibitor of this xanthine oxidase. That's why it is known as suicide inhibition, which it is used in the treatment of gout. The first metatarsophalangeal joint is involved in the gout. There is deposition of urate crystal, monosodium urate crystal on the joint. When the uric acid goes above 7 milligram per deciliter, the monosodium urate crystal deposited in the joint, it causes the gout. It causes the gout. Primary gout, there are number of reasons for the primary gout. It is because of the increased activity of PRPP synthetase, increased activity of PRPP glutamine amidotransferase, then decrease G6PD, decrease in the glucose 6 phosphatase, that is von Gogh disease, then HGPRTase deficiency, that is in the Leishnian syndrome, and increased glutathione reductase activity. These are the 5 important reasons for the gout. And the confirmatory test is the aspiration and microscopy. Aspiration from the joint, synovial fluid from the joint, and microscopy, and watching the negatively birefringent crystals in the microscope is the diagnostic for the gout. First metatarsophalangeal joint is most commonly involved. Here identify the drug Z. Identify the drug Z here. This is vitamin K epoxide reductase. This is vitamin K epoxide reductase. It is a competitive inhibitor, that is dicumarol. Dicumarol or warfarin is the oral anticoagulant which is given. This is oral anticoagulant and it inhibits the enzyme vitamin K epoxide reductase. It is a competitive inhibitor of vitamin K epoxide reductase. Okay. It is required for the conversion of oxidized vitamin K into reduced vitamin K. Vitamin K is very, very important function. It is important for post-translational. Vitamin K is important for post-translational gamma carboxylation. Gamma carboxylation of clotting factor, and it activates the factor 2, 7, 9, 10. Activate the factor 2, 7, 9, 10, vitamin K. So warfarin, dicumarol, oral anticoagulant drugs inhibit the vitamin K epoxide reductase, oral anticoagulant. These are the examples of competitive inhibitors. इसमें से methotrexate याद रखो एक methotrexate. This is methotrexate. It inhibits the dihydrofolate reductase enzyme. Then xanthine oxidase, it is inhibited by the allopurinol. Okay, lovastatin, it is used to reduce the cholesterol level in the atherosclerosis and cardiovascular disorder. It inhibits the enzyme HMG coenzyme A reductase. HMG coenzyme A reductase. This is a graph of competitive inhibition, X-shaped graph. Whenever you see the X-shaped graph, it is a competitive inhibitor. Competitive inhibition. In the competitive inhibition, Km increases and Vmax remain unaltered. Km increases, Vmax remain unaltered. X-shaped graph, competitive inhibition, Line-Weaver-Burke plot, competitive inhibition, X-shaped graph, image-based question. This is a V-shaped graph. It is a non-competitive inhibition. In the non-competitive inhibition, Km remain constant and Vmax get lowered. Remember, Vmax, maximum velocity. There is nothing like increase in the Vmax. There is either it remain constant or it decreases. अगर ऑप्शन में increase Vmax वाला ऑप्शन है तो वो पहले strike out करो. Okay. So in the non-competitive inhibition, Km remains same and Vmax decreases. So V-shaped graph. Image, you may get image-based question on this. And parallel lines, it is a example of the uncompetitive inhibition. Both decreases. Km decreases, Vmax decreases. Now the important question and important topic, that is lipoproteins. A patient has multiple tendon xanthoma. Remember, whenever it is tendon xanthoma and increase in the cholesterol level, go with the second disease, that is hypercholesterolemia type 2A. Okay, hyperlipoprotein. Serum cholesterol level 398 milligram per deciliter. Desirable level is less than 200 milligram per deciliter. And LDL is 220 milligram per deciliter. Were found to be raised. Statins were given given to this patient. What is diagnosis? This is familial hypercholesterolemia. Familial hypercholesterolemia. Lipoprotein lipase defect और familial hypercholesterolemia, ये दो ही करने हैं हमको. Lipoprotein lipase, there is increase in the chylomicron level, there is increase in the VLDL level. While here there is increase in the cholesterol LDL level and there is tendon xanthoma. Here is because of increased TG, there is chances of pancreatitis. Here there is chances of coronary artery diseases. Tanger's disease is again important question but rarely asked. Now see, whenever cholesterol increase and tendon xanthoma is there, means there is xanthoma or lesion on the tendon, involvement of tendon is there, and there is increase in the cholesterol level, it indicates the type 2a type 2a. According to Fredrickson classification, it is a type 2a hyperlipoproteinemia. When there is increase in the TG level, and eruptive xanthomas are there, it indicates the type 1, type 4 or type 5. And when chylomicron is increased, milky plasma is there, it indicates the type 1. It indicates the type 1 hyperlipoproteinemia. So ये इतने सारे क्लासिफिकेशन है, इसमें से पहले दो याद रखो. One is the familial chylomicronemia. Whenever there is milky plasma, increase in the chylomicron level, increase in the TG level, that indicates the hyperchylomicronemia. And whenever because of chylomicron and TG, there is chance of pancreatitis. There is risk of pancreatitis, not coronary artery diseases. So this is familial chylomicronemia. And familial hypercholesterolemia, it is a type 2A. This is because of LDL receptor defect or ApoB100 defect. This is important MCQ. This is also important MCQ. Familial hyperchylomicronemia, it is because of lipoprotein lipase deficiency or ApoC2 defect. ApoC2 defect. ApoC2 defect. Remember these are the important MCQs. And this is due to LDL receptor defect or ApoB100 defect. Here cholesterol increases, LDL increases, there is risk of coronary artery diseases, atherosclerosis, and there is tendon xanthoma in the familial hypercholesterolemia. So remember these two only, 1 and 2A. 1 and 2A. And in hypolipoproteinemia, remember the Tanger's disease. In the Tanger's disease, there is orange color tonsil. Remember this, in Tanger's disease, there is orange color tonsil, and there is mutation in ABC, ATP binding cassette transporter protein. This transport is defective, which is important for transfer of cholesterol from cells to the HDL. Transfer of cholesterol from the cells to the HDL. This is important. So this is defective in the Tanger's disease. So low level of HDL is there. HDL levels are low, and enlarged yellow-orange tonsil. See this. This is yellow-orange tonsil. It is seen in the Tanger's disease. Okay. With reduced level of high density lipoprotein and ATP binding cassette transporter A1, on examination tonsil appeared as shown in the image. It is a Tanger's disease. It is a Tanger's disease. See, Fisheye disease it is a partial deficiency of lecithin cholesterol acyltransferase, and Norum's disease is the complete deficiency of lecithin cholesterol acyltransferase. So these are the characteristics of these lipoproteins. Remember, this is the highest in diameter but least dense. This is the maximum density HDL. Apart in this is maximum protein content HDL. Chylomicron is important for transport of dietary TG, means exogenous triacylglycerol from intestine. It is produced in the intestine, so it transport the TG from intestine to the peripheral tissue, means skeletal muscle and adipose tissue, while VLDL transport the TG, which is produced in the liver, to the peripheral tissues. So these two are important for the transport of TG, while LDL and HDL, they are important for the transport of cholesterol. This is from liver to peripheral tissue. This is from peripheral tissue to the liver. So that's why it is known as reverse transport of cholesterol. These are the different lipoproteins. ApoB48. This is the example of RNA editing. Only intestine, only 48% of B48 is produced. ApoB is produced. So that's why it is known as ApoB48. This is due to the premature truncation of protein synthesis because of incorporation of UAA in place of CAA. So this acts as a stop codon and termination occurs. So this is example of RNA editing. RNA editing. So it is important in the chylomicron. B100, it is important in VLDL and those lipoproteins who are derived from the VLDL, that is IDL and LDL, it is important. Okay, suppose C1, C2, C3. Now C2 activates the lipoprotein lipase, while C3 inhibit the lipoprotein lipase. A1 activates the LCAT, lecithin cholesterol acyltransferase. Next, which of the following vitamin need to be supplied in the diet of patient with cystathionine beta synthase defect? This is the case of homocysteine urea. Homocysteine urea C. If you know the pathway, this is methionine. Methionine is converted into SAM, S-adenosyl methionine, which is a universal methyl group donor by the methionine acyl transferase. Methionine adenosyl transferase, it is converted into S-adenosyl methionine, which is converted into S-adenosyl homocysteine, and S-adenosyl homocysteine is converted into homocysteine. This is a pathway, and this is a pathway. This is a reaction which is known as folate trap, where methyl tetrahydrofolate is converted into tetrahydrofolate, and this is B12 dependent reaction. So this reaction, homocysteine to methionine conversion, is dependent on B12. It's dependent on folic acid. If B12 is deficient, there is trapping of methyl tetrahydrofolate occurs. That's why it is known as folate trap. Now homocysteine is converted into methionine here. Now homocysteine along with the serine, homocysteine and serine will give the cystathionine, and this cystathionine, with the help of cystathioninase, will give the cysteine plus homoserine. Okay, now see this pathway. This is defect here, cystathionine beta synthase. If this is defective, cystathionine beta synthase is defective, it causes, cystathionine beta synthase defect causes the homocysteine urea. Now this is defective. If this is defective, homocysteine level will be raised. This will be raised. See, होमोसिस्टीन लेवल बढ़ जाएगा, मिथ्योनिन लेवल भी बढ़ जाएगा. ओके, तो क्या नहीं बढ़ेगा? सिस्टीन विल नॉट बी रेज्ड. ओके, सिस्टीन का लेवल नहीं बढ़ेगा, सिस्टीन कम हो जाएगा. सो विच शुड बी सप्लाइड इन द डाइट इन पेशेंट विथ होमोसिस्टीन यूरिया. तो होमोसिस्टीन भी बढ़ा है, मिथ्योनिन भी बढ़ा है, सिर्फ सिस्टीन. So we'll supply the cysteine in the diet. So cysteine becomes now the essential amino acid in the homocysteine urea. Now homocysteine urea, there is feature, there is increased homocysteine level, so there is atherosclerosis, there is risk of cardiovascular diseases. Second, because there is production of free radicals which causes the aggregation of LDL particle because of increased homocysteine level and homocysteine level. Second, there is subluxation of lens occur, that is known as ectopia lentis. There is mental retardation also in the homocysteine urea. So cysteine becomes essential and will be supplied in the diet in classical homocysteine urea. Now macrocytic anemia with increased excretion of methyl malonic acid is seen in deficiency of. Macrocytic means megaloblastic anemia के दो important reason है, एक तो B12, एक तो folic acid. Now it is along with methyl malonic acid excretion, means it is B12 deficiency. It is B12 deficiency. Now see this reaction, propionyl coenzyme A. Propionyl coenzyme A is converted into methyl malonyl coenzyme A, and it is converted into succinyl coenzyme A. This is a pathway. This is B12 dependent reaction. This is biotin dependent carboxylation reaction, propionyl coenzyme A carboxylase. Now if there is macrocytic anemia with increased excretion of methyl malonic acid, when there is B12 deficiency, there is mutase, methyl malonyl CoA enzyme mutase deficiency. In that case, methyl malonic acid level increases in the blood, that causes methyl malonic acidemia and excretion of methyl malonic acid in the urine. So this is because of the B12 deficiency. So macrocytic anemia, it is because of B12 deficiency. Now see the next case, megaloblastic anemia with increased excretion of FIGLU, farm-immunoglutamic acid, on the histidine load test. It's seen in, this is due to folic acid deficiency. Folic acid is important for the conversion of farm-immunoglutamic acid. When histidine is given, farm-immunoglutamic acid is excreted in urine in the deficiency of this folic acid. When folate is deficient, this is excreted in the urine. So there is megaloblastic anemia. When FIGLU is excreted in the urine, it is because of folate deficiency. Now this is megaloblastic, large oval RBCs and hypersegmented neutrophil. Large oval RBCs and hypersegmented neutrophil. These are the features of megaloblastic anemia. Now the next question, which of the following is the omega-3 fatty acid? Remember, there is omega-3, omega-6 and omega-9 series. So here answer is alpha-linolenic acid. Alpha-linolenic acid is the omega-3 fatty acid. Omega-3 fatty acid includes alpha-linolenic acid, then the timnodonic acid and the cervonic acid, that is DHA. DHA which is required for the Development of brain and retina. Omega-3 fatty acid includes the alpha linolenic acid. Then second is the timnodonic acid and carbonic acid. Another name is docosahexaenoic acid, DHA. Carbonic acid or DHA. DHA is present in the fish oil. It is present in the breast milk. It is important for the development of brain and retina. So alpha linolenic acid, you can convert this alpha into 3. So this is omega-3 classification. Now the omega-6, it includes the gamma linolenic acid, linoleic acid, and arachidonic acid. Arachidonic acid is the precursor of the eicosanoids, 20 carbon compounds derived from the arachidonic acid. That includes the eicosanoid, prostaglandin, prostacyclin, thromboxane, leukotrienes, lipoxenes. Okay, so these are the omega-6. Omega means starting from the methyl end, there is double bond is there. Double bond is there. First double bond is there at the omega-6 carbon. So starting from the methyl end. Omega-9 is the oleic acid and the elladic acid. So oleic acid is the most common fatty acid in our body, constitute about near 50% of the fatty acid in our body. So this is the most common fatty acid in our body. So remember, alpha linolenic acid is the omega-3 fatty acid. Alpha linolenic, timnodonic, and the carbonic acid, that is DHA. डोकोजा, डोकोजा मतलब, डोकोजा का मीनिंग होता है, डोकोजा मतलब 22, हेक्सा, डोकोजा हेक्सा means 6 double bond, and डोकोजा हेक्सा enoic acid. Okay, so this is DHA. So omega-3 fatty acid, this is important. Apart from this, the respiratory distress syndrome, RDS, it is due to deficiency of dipalmityl lecithin. Dipalmityl lecithin, respiratory surfactant which prevent the collapse of the lung at the end of expiration. So LS ratio, lecithin sphingomyelin ratio, it should be more than 2. It should be more than 2. That indicates the fetal lung maturity. The type 2 pneumocytes, they are produced later in the fetal life. So because of deficiency of type 2 pneumocytes, the lecithin is not produced, and LS ratio is less than 2 in case of premature birth. It causes the respiratory distress syndrome, rapid respiration, flaring of alainezy, the respiratory discomfort is there, and the cyanosis is there. Cyanosis of the lips, tongue, finger is there in the respiratory distress syndrome. So lecithin sphingomyelin ratio is important. It should be more than 2 for the fetal lung maturity. Respiratory surfactant includes the dipalmityl lecithin, then dipalmityl glycerol, palmityl phosphatidyl glycerol, then the surfactant protein A, B, C, and cholesterol. So it lines the alveoli, inner surface of the alveoli, and prevent the collapse of the lung at the end of expiration. So this is all about the important topics which are frequently asked in the FMGE examination. Also watch the FMGE sprint and FMGE part 1, part 2, which is already there on the Med Ed channel. Thank you all of you.